So thank you very much. I apologize, I'm not able to be there in person due to some visa problems. I still haven't got my US visa extended. Hopefully that will happen quite soon. So next time, whenever you invite me, I'll make it a point to be there in person, because I've so much enjoyed your hospitality and I've visited you several times in New Jersey. So the topic of my presentation is impact of large South Asian community-based studies with diabetes as a risk factor for CVD. At the outset, as a disclaimer, let me mention that, as was mentioned in the introduction, I'm a diabetologist, I'm not a cardiologist, so probably the odd one out in this particular group. So I'll try to focus a little bit on cardiovascular disease, but my main talk will center around diabetes. Now, we have heard and we all know that diabetes is a huge problem in India. Now, these data come from the ICMR, the Indian Council of Medical Research, India Diabetes Study, or the ICMR in-diet population-based study. I'm happy to tell you that we have now completed the whole country, all the 30 states of India. But when we finish the first 15 states, we published this report in Lancet Diabetes Endocrinology, where we show that there is a huge variation in the prevalence of diabetes in India in different states. For example, if you look at Bihar, one of the little poorer states in India, the prevalence of diabetes is only 4%, as compared to the Union Territory of Chandigarh, for example, where it was 13.6. When we completed the remaining 15 states, and by the time, of course, a few years had passed to completely do this whole study, there are states like Kerala and Goa and Puducherry or Pondicherry, where the prevalence of diabetes is now over 20%. It's almost in the region of 25%. This slide shows you something very interesting as well. What's shown in blue is the GDP of each state. And you can see that there's a fairly good correlation between the GDP and the prevalence of diabetes, which means in the poorer states, there's less of diabetes, and as the state advances, there is more obesity and more type 2 diabetes. And of course, that's something which you should try to prevent based on this study. Let me now switch tracks and talk about something which might have been discussed by earlier speakers, because I know that Raj, Gopal and others have been speaking in this conference earlier. That's the South Asian phenotype, also called as the Asian Indian phenotype. Now, this makes people of South Asian origin more prone to both type 2 diabetes as well as to cardiovascular disease. I'm not going to belabor the point by going through all these 13 variations that we see, but suffice to say that the lower age at onset of type 2 diabetes is very well known. So both cardiovascular disease as well as type 2 diabetes tend to occur at least 15 to 20 years earlier in the South Asian population. There is also a low BMI threshold for BMI for type 2 diabetes, which means that we tend to get diabetes when you're much thinner. There's a rapid decline in beta cell function. And number 5 is something which I've been very intrigued by. I'm sure this audience knows that South Asians have the lowest HDL cholesterol reported among all the ethnic groups, with very high triglycerides and small dense LDL and lower levels of adiponectin and so on. So many of these factors make South Asians more prone not just to type 2 diabetes but to cardiovascular disease as well. Now, there is a huge burden due to the complications of diabetes. For example, coronary artery disease, which is what we're interested in today, but also vascular disease, retinopathy, nephropathy and neuropathy. And you can see that there are some urban-rural differences. For example, the prevalence of coronary artery disease is 21% among all diabetic people studied in this population-based study, whereas in rural areas it was less. Not surprisingly, because they are thinner and they tend to exercise more, probably they are poorer and therefore they eat less of the rich foods and so on and so forth. Some years ago, we wrote this review to say that there is a parallel between type 2 diabetes and cardiovascular disease. For example, if you look at some of the risk factors, starting with age, male gender, family history, physical inactivity, diet and so on, they are all common to both diabetes and to cardiovascular disease, and which is not surprising. Why? type 2 diabetes is often referred to as a cardiovascular risk equivalent, which also means that if we focus on these, for example, the unhealthy diet, obesity, physical activity, and so on, we can have two birds with one stone shot, as so to speak. We can prevent not only diabetes but also cardiovascular disease. This is a paper based on a CURE study where we tried to look at cardiovascular death after 10-year follow-up of the CURE's patients. CURE stands for Chennai Urban Rural Epidemiological Study. It's a representative study of Chennai. And after 10 years, when we looked at the mortality, we found that the overall deaths, the ischemic heart disease related deaths as well as cerebrovascular deaths were all considerably higher in people with type 2 diabetes compared to those without diabetes. In other words, the clock starts ticking, not just after the diabetes comes, but at the stage of impaired glucose tolerance itself. This is a paper in JACC published many years ago where we showed that the overall prevalence in the population of coronary artery disease was 9% non-diabetic patients, 14% in impaired glucose tolerance, and over 20% in those with diabetes. Recently, 2020, we were part of the CURE study, and I know that Salim Yusuf, my good friend, is there at this meeting, and he has been honored with an award in this meeting. I hope he's still around. As part of the CURE study, in which we are also a collaborator, we looked at the cardiovascular mortality rates as well as cardiovascular disease in people with and without diabetes in the low, middle, and high income countries. And why do we do that? Because there is evidence now from the United States, as was shown by Dr. Hong in his previous presentation, that cardiovascular disease rates are actually decreasing in some of the developed countries like the United States. So the question was, what is the relationship now in 2020 in this large study, the CURE study, on almost 150,000 people from 21 countries? The data is shown here. Panel A refers to cardiovascular disease. In yellow is people with diabetes, and in purple is people without diabetes. So you can see that in high, the middle, and the low income countries, no doubt that you have more cardiovascular disease if you have diabetes. But I'd like to draw your attention to panel B and panel C, where you can see that in the low income countries, whether it's the all-cause mortality shown in B or the cardiovascular mortality, CVD mortality shown in C, if you look at the low income countries shown here and look at the mortality in those without diabetes, it is actually far higher than those with diabetes in the middle and the high income countries. This was a very striking figure when we published this, and it created a lot of interest. And the same thing for cardiovascular disease mortality as well. If you look at the cardiovascular mortality in those without diabetes, in the low income groups, it is actually much higher than those with diabetes, almost threefold higher than those with diabetes in the high income group. And in this paper we make a case that it's the better health facilities and also the better use of aspirin, statins, and the adherence to the anti-diabetic drugs and the blood pressure drugs and so on, which has resulted in a marked lowering of the cardiovascular disease and mortality in the high income countries, but the low income countries are far behind. And that's the conclusion of this paper, which is shown here. Moving on, what are the goals of diabetes therapy? So I simplify this and call it as the A, B, C, D. A stands for A1C, and the A1C should at least be less than 7%, if not below 6.5%. The blood pressure, I have very liberally put it as 140 by 90, and I'm sure a cardiologist in the audience will say, no, we want it at 130 by 80, but I'm talking about a population-based figure, and if we achieve 140 by 90 for everyone, I will be very, very happy. And I'll show you the results from India, which are not at all incorrect. Cholesterol, let's take LDL cholesterol. Again, I'm very liberal, less than 100 milligrams. I know you cardiologists would like it to be at 20 or 30 milligrams, certainly below 50, but I've just taken 100 milligrams as an upper limit and said at least that if you're able to achieve. And D stands for discipline. Into this I have bundled diet, exercise, no smoking or tobacco, moderation alcohol use, stress reduction, and most importantly regularity of follow-up, because we have found that the last one, in fact, determines whether you achieve A, B and C. So if they don't come for follow-up at all, or they come once in 2 or 3 years, you're not going to achieve A, B and C. So the question is, why is this so simple, A, B, C, D? What is this at the population level, and have we really achieved that? Are we achieving these goals? Now, very recently in Lancet Diabetes and Technology, we published ICMR INDAB paper number 13. And the title of the paper is Achievement of Guideline Recommended. So the same A, B, C, D in different states of India. This is after completing the whole study. So in the entire country. So we have more than 113,000 patients who have been studied. What we did was, we color coded it as good, satisfactory and poor using the similar cutoff which I just presented. A1C less than 7, 7 to 8.9, more than 9, systolic blood pressure 140/90 up to 159 systolic and above 160, LDL similarly classified as less than 100, 100 to 129, more than 130. We also had whether they're taking enough fruits and vegetables, physical activity and so on. Remember, this is for the whole country. The whole of India, 1.32 billion people who have been representatively sampled. Now here are the results, and I'm not going to show you this complicated slide, but in a nutshell, green means that you have achieved those goals. The orange means that you have not, or the pink shows you that you are not quite there, and the red says that you are far away from the mark. So if you look at A1C, not a single state in the country, and these are only among self-reported diabetic patients, which means they already know that they have diabetes and they are on treatment. We are not even talking about the undiagnosed diabetes. Not a single green. Most of it is pink or red in some states. Blood pressure, not too bad. Quite a lot of these, because we use 140/90, quite a lot of the states had this mean blood pressure of everyone in the state who had diabetes in the survey. Diastolic blood pressure, not too bad. We look at LDL cholesterol, quite a lot of greens there. Look at this depressing thing at the end, physical activity. Almost the whole country is red, showing that they are not achieving the 150 minutes per week, which has been set down by WHO. This is summarized a little better in this graph, is more easily readable. If you look at A1C, about a third of people, whether it's in urban India, rural India, males, females, or overall, only about a third have their A1C below 7%. About 50% have their blood pressure less than 140/90, and about 60 to 70% have their total cholesterol less than 100, or their LDL cholesterol slightly worse, about 40%. But not too bad. The lipids not going too bad, blood pressure a little worse, and the worst of all is, unfortunately, the glycemic control. And of course, you have all the other figures for physical activity and so on. You can see only about 20% of people achieving the physical activity goals. So we concluded saying that if you take all the three together, if you take A, B and C, the A1C, the blood pressure and the lipid parameters, the LDL, only 7% of those who have self-reported diabetes in India have achieved the A, B, C. Now these are quite shocking figures, and it's a wake-up call for everybody, for the public health people as well as for endocrinologists, cardiologists and everyone in the country, physicians, to say we have to do a lot more. We have to get those A1Cs under control and the blood pressure and the lipids under control. So the next question you will turn around and ask me is, okay, Dr. Mohan, if we achieve this A, B, C, D, can you guarantee that you can live a long and healthy life with diabetes? In biology, there are no guarantees, as we all know. There's no 100%. However, in this paper, this is the paper which actually got me the Harold Rifkin Award from the American Diabetes Association. In 2013, in Diabetes Care, we published on the clinical profile of long-term survivors and non-survivors of type 2 diabetes. This was a series. We had 200,000 patients whom we had followed up, and we had 238 survivors, which meant that with type 2 diabetes they lived a minimum of 40 years and some of them 50 years with type 2 diabetes. How is it possible that they can live 40, 50 years with type 2 diabetes when they get it late? But that's the point, that in South Asians they get it much younger, 20s and 30s. So if you add 40 years to them, they're only 60 or 70 years old. So it is possible to do this in India. I've not seen this being reported from the United States, for example. So what did we find? What is the difference between the survivors and the non-survivors? No big guesses there, because they had better glycemic control, that's the A, blood pressure control, that's a B, and the lipid profile, that's the C. And that's where the A, B and C came from. More recently, we published a report on elderly patients above 90 years of age. It's always been assumed that type 2 diabetes or even type 1 diabetes for that matter shaves off 10-20 years of your life. So we collected a series of patients, almost 300-400 patients, who had completed several years of diabetes, 30-40 years, and now were beyond 90 years of age, and some even crossing their 100th birthday. Now, seeing is believing, and here is a picture of some of them. We call them in groups to our center. There are two people here who are less than 90 years old. I think you can guess both of them. One is me and the other is my daughter. Everyone else, believe it or not, in this picture is above 90 years of age. This gentleman here sitting in the wheelchair had crossed his 100th birthday, and he was the chief guest for the function. He was the vice chancellor of two universities actually in his lifetime. This gentleman here was the chief secretary of our state. He has served 4 prime ministers of India and 4 chief ministers of India. At that time he was 97 years old, and he had just published his book a year ago. Very recently he celebrated his 100th birthday and is still doing well. And he actually came for his 100th birthday celebration. Many of the people here are 99 and 100 years old. They all have type 2 diabetes of 40, 50 years at least, if not more. Some of them even 60 years duration. So you can see that it's possible today to have survival of people with diabetes for a long time. Now, but then the choice of the anti-diabetic drug also matters, and this is very important for all of us, and I'm sure as cardiologists will all agree that the SGLT2 inhibitors have played a major role today in the treatment of heart failure and in the treatment of cardiovascular disease and risk reduction in people with diabetes. This is the EMPA-REG outcome trial, which shows you that people on empagliflozin start improving, and the risk reduction starts even within a month after starting the empagliflozin. You can see that the curves are beginning to separate out. In the overall study, there was a 38% risk reduction in those who used empagliflozin with a hazard ratio of 0.62. What about the Asian patients? In the same study, it was shown that if anything, the Asian patients did better, 56% reduction. In a subsequent paper, we also showed that even as far as the A1C reduction is concerned, the Asians seem to do better, and the hazard ratio is 0.44. So you can see that the empagliflozin working very well. And this is a point that it starts very early. This is 180 days, and you can see that even within 30 days, the graphs are beginning to separate, and it's sustained for 4 or 5 years now. So it also matters what drug you use for treatment of diabetes. In the last part of my talk, I'm now switching gears to tell you all that is fine when you're looking at people who come to the clinic and you're trying to offer them care. What about rural India? Now, fortunately or unfortunately for us, 72% of the Indian population lives in rural areas, but 75% of the doctors practice in urban areas. This has been the case for the last 100 years. From the time the British till today, we have not been able to change these ratios considerably. Now, there are several challenges to rural diabetes care, including poverty, access problems, and lack of specialized diabetes care. So how do we take specialized diabetes or cardiac care, or prevention for that matter, to rural India where most of Indians live? So we thought that we should develop a model, and we call this as the 6A test. Now, what's the 6A test? This stands for making diabetes care and cardiac care available, accessible, affordable, appropriate, acceptable, and accountable in rural India. Now, how do you do that? While we were discussing this, I got a call from a zamindar. A zamindar is a person who owns the whole village in the good old days. Now they don't own it, they're just zamindars now. So this is Kanchipuram district. Now that's Chennai. For those of you who don't know where Chennai is in India, this is Tamil Nadu state, and that's Chennai, this is Kanchipuram district. The southern end of Kanchipuram district is Chunamed. So I got this call from this zamindar who said, I've been hearing of your great work and I have a lot of land to give away, so would you like to come and tell me and present the project to me, and I'll be happy to give you a few acres of land. if you tell me what you can do for my people of this village. So I thought about it and I said, you know, we don't have a model for rural diabetes care. So why don't we develop a Chunampet model for rural diabetes care? Chunampet, of course, is the village. So we said we'd start with that village and spread around 30, 40 villages or so, and then scale it up later. So we got support from the World Diabetes Foundation and the Indian Space Research Organization, or ISRO. So using that money, we built this, this van, and inside this van, you have all the facilities for screening for diabetes and its complications, including the eye, the kidney, the heart, the feet, and everything can be done. Dopplers, ECG, everything can be done. And the van can go from village to village screening people, as shown in this video. You can see that people go, inform the people what they are doing. We take young men and women from the village, train them to do, because we can't get doctors there. So we train them to check blood pressures, to check the sugars, and then after getting informed consents and maintaining all the principles of good research, good clinical practice. And then if somebody has diabetes, they don't have to worry. They just step into the van, into the bus, and there they can have a complete checkup of all these systems, including the feet, as you can see, the eye. This gentleman is looking for cataract. He is now going to take a picture of the eye using a retinal camera, and then he can transmit the images instantaneously to our base hospital in Chennai, where the ophthalmologist sitting there is talking to this lady almost 200 kilometers away, telling her what we have done. We built in the land given by the Zamindar, we built a follow-up center, and we hired a doctor from there, Dr. Rakesh, who has been looking after these patients for the last several years. The results were spectacular. We were able to provide diabetes education to over 200,000 people, and the adult population, total population 50,000, to the adult population, we were able to screen them all and then screen for the complications of diabetes in all of them, and then also get the first data on rural complications of diabetes, and most importantly, bring down the A1C levels from 9.3 to 8.4, 8.5, and we are further able to bring this down with a passage track. How did we do this? We used very low-cost generic drugs. You may know that the medicines in India are probably one of the cheapest in the world. They are probably much cheaper than even in Bangladesh, in Pakistan and Sri Lanka. And so they are very, very cheap. And the generic drugs are affordable by even very poor people. So using that, we are able to achieve this. This of course created a lot of interest. The first was in the Lancet, where in the main Lancet in 2011, there was an article on chronic diseases in India, where the Chunampet Rural Diabetes Project was highlighted. And what they said was that the Chunampet Rural Diabetes Project does seem to be a good model for delivering preventive and therapeutic health care to the poor people. And this model can of course be used in other developing countries as well. We had CNN come and do programs, the Discovery Channel, the BBC, we had business magazines write about it. This is the Le Monde, the French newspaper, who had a first page, full page devoted to this. And for those of you who know French, what's written in the headline is that in India, the poor can now afford treatment. So, and then in this book, Jugaad, which means innovation, there's a whole chapter devoted to, this book is not on healthcare at all, it's just an innovation, and with Ratan Tata writing a foreword and so on. And in this, there is a full chapter devoted to the Chunampet model. So this has been something which we have now replicated, we have extended to other villages. The government of Tamil Nadu took it up and made use of it, and the central government has also shown interest in this. So I'd like to end, ladies and gentlemen, by giving you a few take-home messages. The prevalence of both diabetes and cardiovascular disease are high globally, and the bulk has now shifted to the low and to the middle income countries. So if you take the whole of diabetes, India and China alone have 40% of the entire diabetes burden in the whole world. If you add the rest of Asia, it will go up to more than 50%. Both diabetes and CVD share common risk factors. I've shown you how simple it is the mantra, the A, B, C, D mantra, the A1C, the blood pressure, cholesterol, and the discipline part of it, which includes diet and physical activity. If you just bring those in, you can help to reduce morbidity and improve survival, as I showed you in some of our published results. The use of anti-diabetic drugs like the SGLT2, there are others, the GLP-1 receptor analogs, metformin, there are others, but specifically the drugs like the SGLT2 group may benefit both diabetes and CVD. And with that, I would like to thank the organizers once again. If I'm able to take some questions, that would be great.